In 2005, as a parent of a 22-year-old, I got a call that every parent dreads. My 22-year-old daughter had been hit by a car and was taken to a local tertiary care hospital uh, in a very unstable neurologic condition. She had had a severe concussion. She had a very severe knee injury and multiple pelvic fractures. She had appropriately been CT'd from head to toe, as she was not reliable neurologically at that point. She had a head CT, she had a neck CT, she had a chest, abdomen, and pelvis CT, as well as a CT angiogram of the cervical and intracranial vessels because she had a basilar skull fracture, which was adjacent to the right jugular foramen. All of these exams were appropriate. On day 2, she had a repeat head CT scan, again, entirely appropriate. On day 3, having had her hematocrit drawn from the line where her saline IV was running, her hematocrit went down. Big surprise. Rather than utilizing common sense, the team at this point ordered another abdomen and pelvis CT scan with the idea that she had had possibly a large intraperitoneal or retroperitoneal bleed. She went down to the CT scanner. She had a study and had a small amount of fluid in the cul-de-sac of the pelvis, which, as we all know, is very, very common in patients this age. Rather than leaving it at that, realized that she had not had any clinically significant bleed. The resident and the attending physician wanted to repeat her pelvis images following a delay so that more contrast was in her bladder as she was quite thin. And then after that, wanted to repeat the study in 3 to 4 hours, surmising that she had had a very large hematocrit drop and that she needed further imaging to see if the amount of free fluid in her belly was changing. At this point, her father, a practicing radiologist, decided that that was enough. No more images were obtained. I refused that she have any further imaging. At that point, I became a zealot for radiation safety, having seen with my own eyes what was happening to young patients with helical CT scanning, given its ease of doing, its power, and its seeming ability to answer any and all questions. At first, my cries were thought of in the wilderness as not being heard, and I quote Arthur Schopenhauer in this slide, a 19th century German philosopher. All truth passes through 3 stages. First, it is ridiculed. Second, it is violently opposed. And third, it is accepted as being self-evident. Initially, I was ridiculed. Many people said, why do you want patients not to have CT scans? It's bad for business. It's not safe medical legally. It's just not right. It was violently opposed by many radiologists, by many emergency room doctors. And now I'm happy to say, 8 years later, this has been accepted as self-evident, and that radiation safety is part and parcel of the operations of virtually every radiology department in this country. Recent events, and let's just go through them. My daughter was injured in 2005. Brenner and Hall published a review in the New England Journal of Medicine. These two radiation biologists and radiation physicists at Columbia were the first to describe the potential dangers of CT in pediatric patients in 2001, which led to an FDA alert. But they continued with their work and published what I would consider a landmark article in the New England Journal of Medicine, of which the header of which I have here on the slide, about computed tomography, an increasing source of radiation exposure. In 2009, Cedars-Sinai Hospital in Los Angeles had multiple episodes of hair loss in patients getting CT perfusion studies, which got a lot of press and pointed out the possibility of overexposure in single studies. Dr. Smith-Bindman, who is the organizer of this conference, has done some very valuable work in this area. In 2009, she published an article in the Archives of Internal Medicine pointing out the variable output by a factor of 13 of San Francisco Bay Area CT scanners. The FDA, responding to these events and alerts in 2010, began an initiative to alert clinicians and patients about CT exposure issues. In 2010, California began requiring dose data to be reported. In 2011, JCHO issued directives on radiation safety and diagnostic imaging. In 2012, California mandated exposure data on CT reports. So, what are the various radiation doses that are of concern? These are, again, our gross estimates. On the left are radiation dosages and effects. And as you can see, what we're dealing with in the area of diagnostic radiation exposure is in the low numbers. We're not going to be dealing in the 10,000 millisievert range where patients will die, or patients get radiation sickness in the 1,000 millisievert range. Instead, we're dealing with ranges of exposure often under 100 millisieverts cumulatively in a patient. But note that the occupational exposure limits of 20 millisieverts per year, averaged over 5 years, is the highest recommended allowable dose for radiation workers. 3 to 5 millisieverts per year is the typical dose rate of uranium miners. The estimated radiation doses of common medical procedures are listed on the right-hand side of the slide. The chest X-ray, minuscule, 0.1 to 0.2 millisieverts. The head CT, 2 millisieverts. And it's important to note that the head CT actually has very high exposure parameters, but the head, eyes, etc. are relatively insensitive to the effects of radiation. Chest CTs and CT pulmonary arteriograms are in the range of 8 millisieverts per examination. Cardiac CT is variable depending on whether it's a male or a female. Renal stone CTs often average in the 10 millisievert range. And you see these go up to PET CT fusion studies of 20 millisieverts. Of note is, since I made this slide, is the manufacturers have worked very hard to diminish radiation exposure. And now I'm happy to say that you can often do low-dose examinations in thin patients where you can get easily 1 millisievert exposures for a chest or even an abdomen and pelvis CT. These parameters change dramatically in obese patients where more exposure is necessary in order to make the image diagnostic. What is the scope of the problem? CT is about 15% of the volume of radiographic procedures, but 60% of the estimated population exposure from diagnostic radiation comes from CT. At my prior practice at the Southern New Hampshire Medical Center, when I first started there, we did 2,000 CT studies in 1985. We did 18,000 studies in 2006 and over 20,000 studies in 2009. The outsourcing of CT readings and off hours to the teleradiology companies has made it very easy to do CT studies in all situations in community hospitals. Technologists are invariably that are trained in CT are available in these hospitals 24/7 and so that CTs can be ordered by emergency room or hospitals, physicians, uh, virtually any time of the day or night. It's important to note that many patients under the age of 40 years old may be subjected to many CT studies with little clinical benefit and the real potential for radiation-induced carcinogenesis. Do we know that CT causes cancer? No. Do we know that CT is extremely valuable in the management of certain conditions in patients and can in fact be life-saving? Absolutely. Where are the patients where clinical concerns can be raised for the practicing physician, radiologist, surgeon, cardiologist, uh, anyone really who is ordering and or supervising these studies? In young patients, repeat imaging often happens in patients with chronic abdominal pain, with pancreatitis, with Crohn's disease, with diverticulitis, trauma, follow-up of pulmonary nodules, and respiratory symptoms and chest pain in young women. Appendicitis in young patients for other conditions that has classic clinical features. Does a CT need to be done? That's controversial. There are many surgeons who would feel comfortable taking those patients directly to the OR without CT. There are many others, and certainly more and more, who want the CT done before going to the OR. And it has been shown dramatically that CT will decrease the rate of false positive laparotomies in appendicitis. It's important to note, and I'll emphasize this again and again, there are situations where CT radiation is not a concern. Elderly patients should not be concerned about getting CT scans because the lag time for carcinogenesis is such that it is not an issue. Adult cancer patients should not be concerned. They already have cancer. CT is absolutely instrumental in their follow-up and they do not need to be concerned about those issues. In the acutely traumatized patient, helical CT has enormous clinical benefit. It is non-invasive, it is fast, it is safe, it is highly accurate, it will give a prognosis for the patient, it will guide surgical management, and it will provide whole body imaging for accompanying injury. This is a case report of a 22-year-old female hit by a car while jogging. She was brought to the ER, confused with multiple injuries. She had a basilar skull fracture with frontal contusions, non-displaced sacral ala and pubic rami fractures, and a posterolateral corner injury of the left knee. Acute therapy was observation and support. Initial imaging evaluation in this patient was a head CT, a cervical spine CT, a neck and cranial CT angiogram, a chest CT, and an abdomen pelvis CT. Day 1, she had a head CT as follow-up. On day 2, she had a head CT, an abdomen pelvis CT with repeat images through the pelvis. And then the patient's father refused further images through the pelvis. On days 3 through 5, she had 3 additional head CTs. The total estimated radiation exposure for this patient was approximately 50 to 60 millisieverts. This patient is my daughter, as you can see here, with her in a CT scan room with me and a copy of her book that she wrote concerning her episode of trauma and subsequent recovery. What can we do? How can we help? Well, the most important thing is education, spearheaded by radiologists. Radiologists are the only specialty trained in radiation biology and radiation physics as part of their residency. A radiologist at each institution that has a CT scanner and doses out radiation should be seen as the radiation safety champion, and they should spearhead all of the efforts in this direction. Radiologists need to re-educate themselves and their colleagues as to radiation biology, radiation physics, and radiation safety issues. Emergency room physicians need to learn more. Cardiologists and surgeons need to learn more. And in the institutions that I work in, we have instituted fluoroscopy credentialing for all users of fluoroscopy. We encourage evidence-based practice. We encourage the use of non-ionizing modalities as alternatives. And we have a long-term commitment to institutional culture change. The question is, all the time, will the study change management? If it won't, particularly in young patients who've had repeated studies, then it really shouldn't be done. These are four frames from a patient with long-standing Crohn's disease, and most institutions now are doing MR enterography as a routine. This is a patient with a stenotic segment with more proximal stenosis and enhancement on post-contrast, really demonstrating the utility of MR enterography in the evaluation and management of Crohn's disease. These are patients who often had many CT studies and now are not getting those and instead are getting MR enterography with, in many ways, better quality evaluation than with CT. In the Southern New Hampshire Medical Center, where I previously worked, I set up a program to identify younger patients who had been frequently exposed to radiation through CT. How did we do this? Well, we found patients who were under the age of 40. Why 40? 40 is the age in the atomic bomb survivor data where patients below that age who were exposed had an increased risk of cancer. These patients had benign diagnoses. They were not cancer patients. We used an estimated 50 millisievert lifetime threshold dosage estimate. Why that? Again, the atom bomb survivor data showed pretty clearly between 50 and 100 millisievert of exposure that those patients had an increased risk of carcinogenesis. We reviewed imaging histories by technologists and radiologists, and one of the important pieces of my program was the CT technologists were empowered to review those and report those to the radiologist and the radiation safety officer. Once those patients were reviewed and found, they were further evaluated by the radiation safety officer who reviewed their imaging histories, went through their clinical records and decided whether it was appropriate or not for them to have further studies given their clinical condition. If it was deemed that they should be labeled as a frequently exposed patient, they were flagged in the radiology information system. And so that when the study was ordered, it would come up in the radiology information system that this patient had been frequently exposed and that further CTs should be performed only with consultation between the ordering physician and the radiologist. Certified letters were sent to the providers and the patients. In addition, we did data mining in the radiology information system utilizing crystal reports, and we further refined and filtered that data by eliminating referring oncologists and doing things by patient age. So imaging consultation was required in these flagged patients prior to CT performance. The patient where this originally began was a 14-year-old male with renal tubular acidosis who had had 14 renal stone CTs in a 3-year period. After institution of the program, 3 years went by. He had no CT studies. He had 12 renal ultrasounds and one-shot IVP. Over the course of time, regular imaging consultation occurred, and there was excellent clinician acceptance. This is a slide of the Department of Radiology of Southern New Hampshire Medical Center of the requisition that would come up, and in the middle of the page you'll see it says radiation safety alert. please check with radiologists prior to performance of further studies. And we found this very effective if the study was ordered, that these patients would be reviewed by the radiologist and the technologist and the referring clinician as to the appropriateness of the exam. When patients had more than what we'd estimate 100 millisieverts of exposure, we put them into a different classification of, quote, extreme exposure. Those patients were notified, and the patient was notified by a certified mail. Counseling was offered by the radiation safety officer to those patients to discuss the issues, and we empowered those patients so that they would know when they went to other institutions what they had done and what the issues were. We tried very hard not to alarm them, but instead to discuss the issues in a rational, scientific, and appropriate fashion so that they were aware of the issues, but not hysterical. This is a description of the program, which I published in the Journal of the American College of Radiology in 2008. And in the first year of the program, these are the results that we had. We were requested to do 52 CTs in flagged patients. Of those, 15% were canceled. 15% were changed to non-ionizing modalities, either ultrasound or MRI. One patient insisted on their study being performed despite everybody agreeing that it didn't need to be performed. 30% were done at clinician insistence, and 40% were done following clinician radiologist consultation. There was marked performance variability among radiologists and variable acceptance of the program by radiologists. Some took the Nike approach, just do it, no matter what. Some would leave it up to the technologists. It was pretty clear that there were some radiologists who had a very low rate of study performance with consultation, and others where virtually 100% of the studies were done upon consultation. So clearly, there needs to be more acceptance by radiologists of this issue. The conclusions of this work: imaging departments can do a lot more than just technical refinements to decrease radiation dose to patients, particularly younger patients who may be frequently exposed. Concerted, persistent efforts can result in lasting cultural institution change. Radiology intervention in the imaging decision-making process is well accepted by both patients, administrators, and providers when done in a constructive, rational, and consistent basis. The bottom line is we can make a difference.